Шановні колеги, шановні друзі,
Dear
сьогодні
colleagues,
30
dear
травня,
friends,
17:00 за Києвом,
so it's
і це значить, що ми розпочинаємо наш
1700
другий
Kiev
день
time. That means we
12-го
start our second day
науково-практичного
of our
семінару на
12th
шляху до покращення здоров'я жінок,
webinar
які живуть з ВІЛ-Україна.
about on track to
Даний
improving health of
семінар
women living
створений
with HIV
групою ВИВ,
in
жінки
Ukraine.
проти
It was
вірусів
organized
Європі,
by Wave
яка
Group Women
є
Against Viruses
частиною
in Europe,
сім'ї
which is
ЄАКС,
part and affiliated
Європейсько-клінічної
with EX
асоціації з
Family
питань
European
СНІДу.
AIDS
І ми дуже
Clinical
вдячні
Society,
Wave за
and
підтримку
we are
наших
very
українських
much
лікарів та
grateful to
можливість
WAVE for
поговорити
the
про
support of our
дійсно
Ukrainian
важливі
doctors
теми
and
саме
this
здоров'я
opportunity
жінок
to
із
discuss
HIV.
really important topics, health of women
Декілька
living
слів про
with
нашу
HIV.
сьогоднішню
Just a
організацію.
couple of
Запланований
words
час
about
нашої
today's
сьогоднішньої
organization,
сесії –
our
1
time
година і
for our
45
session
хвилин.
today that
Хочу
we have
нагадати,
planned for
що
1 hour,
трансляція на
45
Ютубі
minutes.
абсолютно
Just to
вільна. Ви можете
remind you that
пересилати посилання
translate that
своїм
broadcasting on
колегам та
YouTube is
знайомим,
free of
яким
charge, so
наш
you can
сьогоднішній
send
вебінар може
the
бути
link to any
цікавий.
of your
І,
colleagues and
звісно,
friends
ми
to whom
завжди
this
наголошуємо,
might
що
be
наші
interesting.
глядачі, наші
And we
учасники
always
є
support that
незамінною
our
частиною вебінару, тому
participants
що саме ваші запитання
and
допомагають нам
always
зробити
are part
дискусію
of
більш
our
цікавою та важливою і
webinar.
актуальною
It's
для вас.
indispensable part of
Отже,
webinar because it's your questions
також єдине,
that
що
help to make it
наприкінці
more interesting.
нашої
And
сьогоднішньої зустрічі стане
another thing
доступне
that
опитування,
by
метою
the
якого
end
є
of our
не оцінка
today's
ваших
meeting,
знань,
it's
а
going to
оцінка
be a
нашого вебінару.
survey
І
offered to
якщо
you.
ви
And it's not
пройдете
to
це
assess
опитування,
your
то ви
level of
отримаєте
knowledge, but just
сертифікат
the level
учасника
or the quality of
нашого
our webinar.
12-го
So only
науково-практичного
when
семінару.
you undergo this survey, you will get the participant's certificate.
Доктор медицини з університетської
And we have a doctor of
лікарні
medicine
Франкфурта
from
з
the
Німеччини,
Frankfurt
яка
University
також
Clinic
є
from
міжнародним
Germany,
головою
who
ВИВ.
is also a
Також
chair
члени
of
співголовують і
WAVE
сьогодні це
today, and
Юстина Ковальська,
co-chairs is
доктор
also Justina
медицини, доктор
Kowalska, doctor
наук,
of
професор
medicine,
медицини
professor of
Варшавського
medicine,
медичного університету,
Warsaw Medical
старший консультант з
University,
лікарні
senior
інфекційних захворювань
consultant
Варшави і
from
Польщі.
Warsaw
І третя наша
Infectious
співголовуюча
Disease Clinic
сьогодні
in
це
Poland,
Світлана
and the
Антоняк,
third co-chair is
яка є
Svetlana
лікарем
Antonyak, and
інфекціоністом,
she is an
науковим
infectious disease
співробітником
specialist,
відділу ВІЛ-СНІДу
researcher
та
at
вірусної
the
гепатитів
Department of
Державної установи
HIV/AIDS viral
Інституту
hepatitis
епідеміології та
at
інфекційних хвороб
the
імені Льва
Institution
Васильовича
of
Громашевського
Epidemiology Infectious Diseases
Національної
named after
академії медичних
Gromashevsky,
наук України та
affiliated with the
заслуженим
National
лікарем України.
Medical Academy of Science, and she is the
Шановні колеги,
honored
я б хотів
doctor
для
of
початку
Ukraine.
передати
Dear
слово
colleagues,
Анет
for the
для
starts,
привітання
I
наших
would like to
глядачів
give the
та наших
floor to
учасників.
Annette for
Анет,
to
прошу.
welcome our participants. Thank you.
Yeah, thank you, Sergey. Well, it's a pleasure to welcome everyone to this 12th Wave Ukrainian workshop. I mean, we carry on, and that's so important. And it's always an honor to me to be invited to join this workshop. And today I'm even contributing a little a mini lecture. So happy to be here with you. And today's topic is HIV in pregnancy, HIV in breastfeeding. We look at guidelines. We look into the German-Austrian situation. We look to the UK. And then, of course, we'll look at the situation in Ukraine. And it will be so helpful to discuss the similarities and the differences. I mean, looking across Europe, we are all looking at the same evidence, but we draw our own conclusions. And based on our local possibilities, we build our national guidelines. So it's really interesting to listen to each other and learn from each other. So happy to be here today. Sergey, I don't want to talk too long, so I give the word back to you.
Дякую, щиро дякую, Анет, що ви
Thank you.
сьогодні з
Thank you
нами.
so much, Annette. Thank you for
Звісно, я
being
впевнений, що
with
нашим
us today. And
глядачам,
I'm
та й нам,
sure
як
that
учасникам,
for
буде дуже
our
цікаво
viewers,
поспілкуватися.
participants, for us, for everyone,
Пані
this
Світлано,
discussion
передаю слово
is
вам.
going to be of interest. Ms. Svetlana, the
Шановні
word is
дорогі
for you.
колеги, я дуже рада вітати
Dearest
вас на
colleagues,
цьому
I'm
12-му
very
дійсно
happy
вебінарі
to
проєкту
welcome you at
на
this
шляху до
12th
покращення
webinar,
здоров'я
EX
жінок
webinar on
на
track to
вільній
improve
ВІЛ
health of
Україна.
women
Щиро
living with HIV
подякувати
in
вам за те,
Ukraine.
що ви
I would like
виявили
to
інтерес та
thank you
знайшли час
for
все-таки
finding and showing
присутні.
interest, for
Я
finding
хотіла
time
сказати
to
декілька
participate.
слова
I
про
would
вас
like to
від лікарів
express
України,
words
доктора
of
Аннет Хабаров,
greetings
яка
from
багато
Ukrainian doctors
років
to Dr.
фахівцем
Annette
провідний
Haberl,
фахівцем
who's been for many years a very important leading specialist on HIV infection, uh, dealing with HIV in women, in pregnant women, and she is the leader in developing recommendations and guidelines to prevent HIV transmission from mother to child uh, in Europe and German. She was quite modest to talk about herself, but we are very grateful, and we all remember when many years ago in Ukraine, where we're just starting to provide care to patients with HIV infection, and we're just starting to prescribe ART. So she was here, she was coming to Ukraine to train us, and in complicated cases today, we still turn to Dr. Annette for support, for help. This support is really important of us. Annette today is the chair of WAVE, and this is the EX group, Women Against Viruses in Europe. So thank you very much, Annette, for being with us. And of course, it's going to be really interesting to hear about new guidelines, new recommendations that were recently developed not so long time ago with regards to women living with HIV, with regards to the ARV drugs, and with regards to breastfeeding. Breastfeeding and chest feeding. And also I would like to say words of gratitude to Professor of Warsaw Medical University, Justyna Kowalska. She is also among top specialists dealing with HIV in Poland, and also she is the head of ECE, and this is the Euro guidelines in Central and Eastern Europe network group. And Professor Justyna Kowalska inspired our webinars on track to improve health of women living with HIV in Ukraine, together with a known and famous doctor and researcher, Caroline Abbey Pop. She is in Ireland today, and she's participating in an event there. And she is working in the Department of Infectious Diseases University Clinic in Bern, Switzerland. And also, hopefully, we will see her, and she was with us yesterday, and also her research is also related to breastfeeding and HIV. Also, I would like to mention Fiona Malkafi, professor who's been working in St. James Hospital in Dublin. Also, she was among those who initiated our webinars with us in summer 2019. There was the first webinar that took place in Kiev, then Lviv, and this is the 12th time that meet, and the interest of Ukrainian doctors towards our webinars with a lot of challenging issues, important issues regarding women's health living with HIV are discussed, and even now in difficult times, during war times, we still continue our activities, although it's online, but this is the sign of sustainability and resilience. So we are very grateful to speakers from Europe, to Professor Ivona Gilis. And Yvonne Gilis is a leading specialist in HIV in the UK. And the British HIV Association is the organization of healthcare professionals interested in the treatment and care of people with HIV. So we'll be grateful to hear the lecture. We are grateful to Galina Shustuk, pediatric infectious disease specialist, who's been working for many years in Dnipro Center of Socially Relevant Disease. And also we are grateful to her because Olena Strizak. We are talking about Olena Strizak, who is the head of Positive Women NGO. So we are grateful to everyone. So regardless of difficult times, air raid alerts, and sleepless nights, we still continue to work together, and we realize that issues, problems of women and children and babies born to them need to be still resolved, and they have to get the support and care. So we today are focusing on important issues, ART in women, pregnant women living with HIV, and breastfeeding management. Moderator today is Sergen Panyak, researcher at the Department of Viral Hepatitis and HIV at the Institute of Epidemiology and Infectious Diseases at the National Academy of Medical Sciences, and he is the member of Scientific Wave Committee. Maybe I was speaking for too long, but you know the words of greetings cannot be too long. Anyways, we are very, very grateful to you.
Щиро дякую, пані Світлано.
Thank you very much, Ms. Svetlana.
Так, дійсно. Ми дуже вдячні вам,
That's
колеги, за
true.
те, що у цей
Dear
складний
colleagues,
час
that's true.
ви
We are
могли
really
нам говорити
grateful
про
to
дійсно
you
важливі речі,
because
які
you
неможливо забувати.
make it possible for us to talk about
Отже,
important
коротко
things
за
that we
нашою
shouldn't
сьогоднішньою
forget. So
програмою.
briefly, according
Розпочнемо ми
to
з
our today's
міні-лекції
agenda,
Annette
so we
Haber.
will start with a mini
На
lecture
шляху
from
до
Annette Haber
нормальності
on
німецька
track to
акційська
normality,
настанова
German-Austrian
щодо ведення вагітності у
pregnancy guidelines
2025 році.
2025.
Далі, як завжди, у нас буде
Then
невеличка
we are
сесія
going to
запитань та
have a
відповідей та
Q&A
дискусії. Колеги,
session
нагадую,
and
що свої запитання ви
discussion.
можете залишати
And
у
I'll
чаті
just
і ми
remind you, dear
зробимо
colleagues, that you
все,
can
щоб
write
відповісти
your
на кожне з
questions
них.
in our chat.
Якщо
We
ж на
will do
деякі ми не
everything
встигнемо
possible to answer them.
відповісти, то ми
In case
обов'язково
we
їх
don't have
зберемо
enough
та
time to
передамо
answer all of them,
наших
so we will just collect them
лекторів вже
and
в форматі
we will
переписки.
send them to
Далі,
our
після лекції
lectures
Анет в нас і
to
після
get the
дискусії
answers.
буде
And after
міні-лекція
that
ВІЛ і
discussion, we
готування
are
грудневого
going
грудне
to have a mini
випробування,
lecture
яку нам
about
представить Іван
HIV and
Геліс,
breastfeeding,
професор
delivered
Брайтонської та
by
Сассекської медичної
Professor
школи
Yvonne Gillies, professor of
Університетського
Brighton and
госпітального
Sussex
тресту
Medical
Сассексу
School.
Національної служби охорони здоров'я
So
Великої
this is
Британії.
National
Далі ще
Health
одна
Service
сесія
of
запитань та відповідей
United
та
Kingdom,
дискусії.
another
І
Q&A
далі
session,
ми перейдемо до
discussion,
третьої
and
нашої
then we
міні-лекції
will
на
switch
шляху до
over to
усунення
our
вертикальної
third mini
публікації
lecture
ВІЛ в
on track to
Україні у
eliminate vertical
2025
HIV
році,
transmission in
яку
Ukraine
нам представить Олена Стрижак,
2025,
голова
delivered
правління
by
благодійної
Olena
організації
Strazhak, head
«Позитивні
of the
жінки» з
board of
Києва.
directors, Positive
Далі ще
Women
одна сесія
NGO
запитань та
from
відповідей.
Kiev,
І
another Q&A
завершимо
session,
ми нашу
and
зустріч
discussion will follow. And
розглядом та
at the
оголенням
end,
клінічного
we are
випадку
going
ВІЛ
to
та грудне
discuss case
вигодовування в
presentation,
Україні. За і
HIV and
проти,
breastfeeding in Ukraine,
який нам
pros and
представить
cons.
Галина
And
Шерстюк,
this is going to be
дитячий
presented by Galina
лікар-інфекціоніст
Sherstuk,
Дніпропетровського
pediatric
обласного медичного
infectious
центру
disease specialist, Dnipro
соціально-значущих хвороб з міста
Medical
Дніпро з України.
Social Center of Socially
Ось
Relevant
така у нас
Disease.
сьогодні
So
насичена,
that's
але
the
дуже
agenda
цікава
for today.
програма.
It's
І,
quite
колеги,
busy,
я
yet
тоді
really
пропоную нам
interesting. So, dear
переходити до
colleagues, I
нашої
suggest
першої
we start
міні-лекції
with our
на
first
шляху до
mini
нормальності
lecture on track to
німецько-акційська настанова
normality,
щодо ведення
German-Austrian
вагітності у
guidelines with regards
2025
to
році.
pregnancy in
Анет,
2025.
прошу.
The floor is yours.
So, hi everyone, I'm pleased to present the updated German-Austrian HIV pregnancy guideline 2025. These are my disclosures. And that's what it's about today. I had to make a selection because it's a real comprehensive document, the guideline. I will give you a very brief overview of antenatal care and screening in Germany, and then step right into the updated German-Austrian HIV guidelines for the management of pregnant persons living with HIV. And I will present the recommendations on how to start ART during pregnancy, so choose the best regimen for the pregnant person, and also on recommendations for continuing ART, and then delivery, and neonatal post-exposure prophylaxis. And last, I'd like to present the new recommendations on the management of breastfeeding in the context of HIV. Let's start with a quick look at the antenatal screening, antenatal care in Germany. We have quite a lot included in this Mutterpass, what we call it, which was introduced a long time ago, 1963. Of course, it has now a different content. We include ultrasound examinations, vaginal examination, pap smear, HPV and chlamydia screening, also offer optional non-invasive prenatal test, which screens for trisomy 21, the Down syndrome, 18, Edwards syndrome, and trisomy 13, Patau syndrome. Do a lot of other things like check the maternal blood group, rhesus D status, irregular antibodies, anemia, diabetes mellitus, hypertension, and so on. What will focus on today is, of course, HIV and look at the infectious diseases that can be transmitted to the fetus and cause harm. We look at rubella serology and screen for HIV, hepatitis B, and syphilis, and optional for tuberculosis and hepatitis C. And you can see in the brackets what is added for HIV. It's an opt-in. So hepatitis B and syphilis, for example, done more or less routinely. You can, of course, always opt out. But HIV, you have to ask the pregnant person and get the permission to perform the HIV testing. And that results in a little lower screening rate for HIV than, for example, for the syphilis. For HIV, it's around 91, 92%. For syphilis, it's always above 95%. So opt-in, opt-out, routine testing really makes a difference. So we decided now to stay, of course, with the opt-in because we cannot change this as a guideline panel, but we strongly recommend to offer HIV testing to every pregnant person in Germany. And just to show you when the new guideline was adopted, it was March 2025, so it's really brand new to say. Let's look at the regime we'd like to start with during pregnancy. And we made quite a few changes here. So this is a busy table. Let's start the top with the recommended regimes. It's a new combination with integrase inhibitor first. And we can choose, or we recommend to choose TDF, FTC in combination with dolutegravir as a once daily regime. Of course, it's not a single tablet regime, but for the first time, we now recommend a TDF, BF-TAP. So put it this way around, so Biktarvy. So we have integrase inhibitor, single tablet regime recommended for pregnant persons. Then we move forward and look at the PIs that's recommended. It's only darunavir, to be honest, boosted with ritonavir, either in combination with TDF, FTC, or TAF, FTC. In Germany, we have a long tradition of using NNRTI in pregnancy, so we recommend rilpivirine either with TDF FTC or TAF FTC. So this also offers the opportunity of a single tablet regime for pregnant persons. Now, these are the recommended combinations. Let's move forward and have a look at the alternative regimes. So for integrase inhibitors, you can also choose abacavir, 3-TC dolutegravir, even though we don't recommend abacavir anymore in non-pregnant adults. We still have it as an option for pregnant persons. We all know the discussion around abacavir. Now, latest with a reprieve study showing that the use of abacavir, the recent use, but also the cumulative use of the drug increases the cardiovascular risk. So we don't want to have it. Here we are talking about young women without comorbidity. That's to put it down. So we still have it in here, but we might discuss that later. And then for the first time as alternative, we recommend a dual regime. So 3-TC dolutegravir, single tablet, which can also be offered to pregnant persons. And we still have raltegravir in our list. Of course, this is a tablet with more pills. And then latest combination as an alternative we recommend is abacavir 3-TC in combination with ritonavir boosted darunavir. And just to point out, darunavir is always given twice daily in pregnancy. And what is most important, whatever combination you choose, is to start as early as possible. We don't have a test and treat policy. We usually wait for the CD4 cell count and also other lab results, also the viral load, of course, but start as early as possible. So we had in the past the opportunity to just wait the first trimester and then start in the second one. We no longer recommend that. So don't lose time, start as early as possible. What about continuing ART during pregnancy? So people getting pregnant already on ART. And we added a list to our guideline. These are actually 2 slides. So listing all the drugs available today that are used for the treatment of HIV. And then we said, do we recommend starting it during pregnancy? And what about continuing the regime? If the viral load is below 50 copies and the treatment is well tolerated. And we also added a column showing the number of first trimester exposures listed in the antiretroviral pregnancy registry. And I have to point out, these are numbers from January 2024. There is an updated table available by now showing an analysis from July 2024. So if you want to look up the most recent numbers, go on the website and check the APR interims report. So what we can see here, not everything is recommended for start during pregnancy, but most of the combinations or most of the drugs can be continued during pregnancy. Only 3 combinations, boosted combinations, have not recommended here in the second column. And these 3 are the combinations with a booster cobicistat, because we know in late pregnancy the drug levels are not sufficient and there is a risk of virologic failure. But all the others, you can make an individual decision with a pregnant person to continue. And these are the other drugs, and the same applies to them. Try to continue wherever it's possible, or the other way around. The strategy is to avoid switching ART during pregnancy because of unexpected side effects and then virologic failure. So you want to have a stable treatment during pregnancy. Delivery and neonatal post-exposure prophylaxis. Well, it's pretty clear. When the maternal viral load is fully suppressed, that means below 50 copies per definition, we recommend a vaginal delivery unless there are obstetric reasons for doing so. If the viral load is above 50 copies, we do recommend a C-section, also intrapartum AZT, and a neonatal post-exposure prophylaxis. But maybe I should get back to the top of the slides, because if the viral copy, the viral load is below 50 copies at delivery, we do not recommend neonatal post-exposure prophylaxis anymore. I don't know if you're aware of it, but the Swiss started in 2016 to no longer do a post-exposure prophylaxis in infants exposed to mothers with a fully suppressed viral load. We had it in our latest version of the guidelines, but we are now making it clearer and say, well, we should not do it if the maternal viral load is undetectable. But then getting back to detectable viral load, I already told you C-section, AZT, and NeoPAP if the viral load is detectable. And there is also a cutoff of 1,000 copies. If the maternal viral load is that high, we recommend a risk-adapted neonatal post-exposure prophylaxis, which usually means a combination, a triple prophylaxis for 4 to 6 weeks. What about breastfeeding and HIV? Well, we just had a German meeting on HIV and pregnancy last weekend, and we have been really lively discussing what we do when we do counseling on breastfeeding in our patients. And sometimes it seems that we ignore all the positive effects of breastfeeding. Here listed some of them on the left side of the scale, and we concentrate too much on the risk like vertical HIV transmission, even we know it's a very, very low risk. And we also still have concerns about the drug transfer during breast milk. And that's all this way because U equals U. Does it apply to breastfeeding? We still can't answer this question. So what do we recommend in terms of breastfeeding now? We stay with the shared decision making, and shared decision making means the person can decide to formula feed or to breastfeed. So we don't put any pressure on that. As long as the conditions are there, the conditions we require is a fully suppressed viral load, and it should be at least 2 times below the limit of detection before start of breastfeeding. And then in terms of monitoring, we changed it a little bit because we had monthly checkup of the viral load. We now recommend to do it in the first month after start of breastfeeding and then every 2 to 3 months. For the viral load monitoring in the infant, we recommend to exclude intrauterine HIV transmission day 1 and then do viral load testing after 4 to 6 weeks, then after 3 to 6 months, and then every 2 to 3 months. And don't forget to check 6 weeks after cessation of breastfeeding. And we don't put any limit to the duration of breastfeeding. So to summarize, the new German-Austrian HIV pregnancy guideline, I would say it allows a new normal during pregnancy and breastfeeding in terms of conception, if the HIV status is different in the partners, in terms of monitoring during pregnancy, in terms of choice for delivery, no neonatal post-exposure prophylaxis if the maternal viral load is fully suppressed, and then a more convenient monitoring during breastfeeding. And to all these settings applies that we need a final viral load testing to exclude vertical HIV transmission in the baby. And what we are still working on now is material for persons interested in breastfeeding, also for NGOs, for pediatricians, for gynecologists, obstetricians, so they can offer leaflets to the people and so they get the information as early as possible. So with that, I think I'm already the end of my presentation and happy to take your questions.
Я дуже хочу подякувати вам,
I would like to thank you really very much, dear Annette, for this wonderful, very informative presentation with new approaches mentioned there. So it's just very recent, very latest as far we understand. So thank you really very much for that. And I would like to ask right away the first question. So as far as we understood that according to the latest German-Austrian guidelines, neo PEP not recommended if mother before delivery the viral load is undetectable. So less than 50 copies HIV RNA copies. But for how many weeks before the delivery we have to do the viral load testing in mother in this case? So when?
Yeah, thank you for this important question. We discussed that a bit because in our last version of the guidelines, we had the last viral load at pregnancy week 36 or later. And now we switched a little bit to week 34 because wherever patients come from, they have to travel to the clinic, they have other kids. So our normal life is sometimes crossing the plans we make. And so we are a little bit more flexible. But we want, for example, for breastfeeding, we want at least 2 viral loads being undetectable before start of breastfeeding. But the last lab check should be at week 34 or later, of course, so close to delivery. So we are pretty sure that undetectable stays undetectable during delivery and start of breastfeeding. You are never 100% sure, but that's what we can do to stay on the safest side.
Дуже дякую. Тобто приблизно
Thank you
за
very
6 тижнів,
much.
так, до
So
пологів.
that means about 6 weeks before delivery, which is week
А про
34.
переліги за 10 тижнів чи
Yeah,
So
можна?
6 to
this is
4
the
weeks.
last one.
Yeah, 6 to 4 weeks, whatever is possible for the woman. It depends on the circumstances, but as I told you, a little bit more flexibility makes it easier for all of us.
Звичайно, ми погоджуємося з цим, тому
Of
якщо
course, and
тому що
we
якщо
really
немає
agree with
можливості,
that,
то і жінки
because
не,
if there
не
is no
соблюдають наших
flexibility, then
рекомендацій,
women
к
would not just
сожалению.
adhere to our recommendations,
Попереднє,
unfortunately. But how about
мені це
the
цікаво, тому що
previous
ми
testing?
зараз
I'm
починаємо
interested.
працювати
Why?
над
Because
нашим
we start
оновленням
to
рекомендацій.
work on the
І в нас
updated
є на
guideline for
36-му
us,
тижні
and we have it now
перед
week
пологом і
36
за
before
10
delivery
тижнів
and
попередньо.
10
Це
weeks
зберігаються
before.
рекомендації чи
So
ні?
is
Чи
this
попередня
recommendation
може
still
бути
valid, or the previous
ще раніше
one can be even earlier,
вірусного навантаження?
like
Як
viral load testing?
рекомендації це регламентують?
Yeah,
So what guidelines say?
Yeah, I mean, we want to offer a chance to all women, even those who are diagnosed with HIV really late in pregnancy. We have many migrants coming to Germany, and so they come in late pregnancy, then the HIV test is performed. So to give them a chance to have a vaginal delivery, to decide if they want to breastfeed or not, because in some countries or in some cultures, it's even more important than in Germany to breastfeed your child. So we want to offer choices, and therefore we don't have a cutoff for like 10 weeks before. So week 30 would be not a thing to be discussed. Of course, we all know the results of the meta-analysis, that the best outcome in terms of vertical transmission is and the mother is fully suppressed, virologically suppressed at the beginning of the pregnancy or even before pregnancy. So we know that it really matters. There has been a huge meta-analysis done by CBE. I don't know if I pronounce her right, a French author, and she shows there can really be a zero transmission, zero vertical transmission if the mother is fully suppressed before pregnancy, by the time she gets pregnant, and stays suppressed until delivery. So there is really seems to be U equals U. But of course, we want to acknowledge normal life, and some women are not suppressed or are not on treatment at the beginning of their pregnancy or diagnosed during pregnancy. So offer fair chances and choices. So we think with the integrase inhibitor, really with the slope and bringing down the viral load really fast, we can try to do our best to get the best conditions by the time the woman delivers.
Дуже
And
дякую,
maybe
Анет.
if I
Тобто
can
двічі
just
за
add, I'm
вагітність і
chair of the
останній
guideline
раз.
panel. Sorry, I'm chair of the guideline panel, but we are a huge group. We also have NGOs in the panel, community representatives. So we listen to them carefully because they stay in a close contact with the people living with HIV and hear their voices. And I mean, we have to look at the evidence. We can't make stupid decisions. So we have to look at the data, at the evidence, but then we are flexible in our recommendations. And this time we really try to move close to normal as possible, to offer normal pregnancy, choices for feeding options, and everything around this neopep to skip it whenever it's possible. So it was normality above this guideline panel when we discussed the changes.
Дуже дякую. Дуже
Thank you
дякую.
very much.
Тобто двічі
Really.
за вагітність
So
і
twice
один
during
раз
pregnancy
на
and
34-му,
one time
36-му тижні.
week
Ну, як
34,
це
36,
можливо,
right?
так?
Is that right?
Yeah, 30, 34, 36, so close to delivery. And then we wanted to make sure, for example, for breastfeeding, to see the woman in the first month after delivery, because it's always a discussion, life is changing, and maybe adherence issues are coming up. So we want to make sure the woman gets along well with the midwife, with the family. So we want to see her in between this time frame of 4 weeks. But then we go away, we move away from this very close monitoring, because if we believe in U equals U, the viral load is not just, increasing by itself. So we want to have normal checkups. So every 2 to 3 months, we really move away from this very, very close monitoring of viral load. So we want to check close to delivery. Is everything okay? Do you get along well with the baby, the new situation, ART adherence? And if she's doing fine, see her every 2 to 3 months. I think that really makes a difference, because women come from sometimes far away, and all these travel issues, they have to spend time and money. They have to find a person to take care of their other kids. So it makes things more, what do I say, not so complicated anymore. So the women and the parents will really appreciate these changes, I think.
Дуже дякуємо.
Thank you. Thank you
Ми теж
really
будемо
very much.
намагатися бути
We
більш гнучкими.
we will try to be
Дуже
more
дякую.
flexible too. So thank you again.
Так, Анет, дуже дякуємо. І в нас є
All right, yes,
запитання і
Annette,
коментарі
thank you.
в
And
чаті
we
від
have
наших
some
учасників. Я,
questions and
напевно,
comments in
розпочати
our
саме
chat.
з
Probably
коментарів.
I will start from a comment.
Від однієї з
It's
наших
a comment from
учасниць.
one
Нам
of our
дуже
participants.
подобаються нові німецько-австрійські
We
рекомендації.
love new
Контроль важливий та
German Austrian
обов'язковий, але
recommendations and
без
guidelines. Control is
надмірності.
important, but without
І ще
too
у
much
нас є
excessive,
декілька
not too
запитань.
excessive
Я думаю,
control. And a
коротких. Ми
couple of
зможемо.
short
У нас ще є
questions
час.
I think
Анет,
we'll be
як ви
able
ставитесь
to
до
cover. Annette,
дефініції ВІЛ
what do you
експоновані
think
діти?
about
Чи
definition
застосовуєте це
HIV
визначення в
exposed
Німеччині?
babies? Do you use the term HIV exposed babies in Germany?
Well, we are still looking for a new term, because, people first language, we shouldn't say HIV exposed. Babies, you can just turn it around the other way. So babies with intrauterine exposure too. So you have the baby first and not the exposure. But to be honest, we are still looking for the perfect term. So, and I think, I don't know if Yvonne will join us. Even people from the UK, the native speakers, couldn't find the perfect term for the kids. These exposed uninfected infants. We shouldn't say that, but I don't know. I always try to put it the other way around, but it's not perfect, and it's long and complicated. So if anyone has a good suggestion, please tell us.
Добре, обов'язково. Ми запитаємося
All
наших
right,
колег.
all
Може,
right. So we
дійсно
will
вдасться
ask our colleagues.
придумати нове
Maybe
визначення.
we will be able to come up with a new
Так, в
term.
нас
All
трошечки,
right.
трошечки дефіцит часу, але
So
це
we
може
are kind of lacking some time,
Ну, нічого,
not
ми все
enough
встигнемо сьогодні, я
time,
впевнений.
but I believe
Єдине
we
одне
are
коротке
okay
буде
in
запитання,
terms of time in
тоді,
general. So maybe
Анет,
just
дякую
a very short question.
за прекрасну
Also, Annette, thank you
презентацію.
again
Чи
for
тестують
wonderful
у вас
presentation.
статевих
Do you
партнерів
do
вагітної
testing
жінок?
for sex partners of pregnant women?
Well, the testing is done by the gynecologist. And to be honest, it's a very rare case that they offer HIV testing. Of course, if the HIV test is positive in the pregnant woman, we in our clinic offer it immediately. But it would be really a chance, because we do have quite a number of people living with HIV not knowing the diagnosis in Germany. This would be a good chance, and it's a missed opportunity not to do so. So if you do the test in the woman, just ask a partner, by the way, have you ever done an HIV test? Would you like to have one? So it would be not a problem of cost coverage, but I think the gynecologists don't ask. So partner testing is something that always happens when the woman's test is positive. Then, of course, we offer it, we perform it, and well, sometimes then you also detect the diagnosis in the partner, in the male partner.
Дуже дякую, Анет. Я думаю, що
Thank
тут
you very much,
Ірина, наша
Annette.
колега, задала
I think
питання
Irina,
з
our
Києва.
colleague, asked
Тому
that she's from
є
Kiev. I think
занепокоєння щодо
there is
можливості
concern
інфікування
with
ВІЛ
regards to
жінці,
HIV
яка
infection.
коли вона вже є вагітною.
So the risk of HIV
її
infection of
партнер
a pregnant woman
позитивний,
while being
то
pregnant. So
є
if
ризики,
her
що вона
partner is
отримає
HIV
ВІЛ
positive, so there is a
під
risk
час
that a
вагітності,
woman
тоді
is going to be
будемо, на жаль,
infected with HIV during pregnancy. And in this case,
приймати
unfortunately,
всі
then
міри. От така
it
от
might
є
be a little late. So even if we do everything, but that
right.
might not be perfect. So that's the concern.
Yeah, we do recommend repeated HIV testing during pregnancy, or even offer PrEP to the pregnant woman if there is an ongoing risk. But to be sure of the ongoing risk, you should test the partner. You're absolutely right, Olena. Yep.
Ще лікар Людмила пише: "Дякую за
And
прекрасну
Ludmila is also
презентацію."
writing, thank you for this wonderful presentation, and other comments.
Запитання є щодо змішаного вигодовування.
And there is a question about mixed feeding, but maybe mixed feeding issues would be discussed after Yvonne's presentation. Of course, we will. I will just voice it now. So if a baby is on mixed feeding, so are the recommendations the same? But there are some details, some specifics there. So whatever we decide now or later.
We have a very detailed section on breastfeeding, mixed feeding, and what does it mean? So what's the definition of is it solid food, introduction of solid food? Is it just additional formula milk? So we can discuss that after the breastfeeding mini lecture, I think, because that's really an important thing. And the most confusing thing is the definition of mixed feeding, to be honest. So maybe we can discuss that later.
Добре, Анет, ще раз щиро дякую,
All
шановні
right. So
колеги.
in this case, dear
Пропоную
Annette,
далі
once again, thank you very
і
much. And
перейти до
dear
нашої
colleagues, we are
другої
moving
міні-лекції
on.
на
So this
сьогодні.
is our
ВІЛ
second
і
mini
годування
lecture for
грудне або
today,
грудне
HIV and
вигодовування,
breastfeeding,
яку нам
chest
представить
feeding.
Івон
That's going
Гіліс
to be presented by
з
Yvonne
Великобританії. Івон,
Gillies
прошу.
from the UK.
Hello, my name is Professor Yvonne Gillies. I'm a consultant working in Brighton, and I'm going to speak to you about HIV and chest breastfeeding, and these are my conflicts of interest. So if we think about transmission, we know from multiple studies dating back to 2008, the HPTN 052 study initially, and then subsequently, amongst other studies, the partner study in 2017, that when an individual on treatment for HIV is undetectable, there is zero risk of transmission. Unfortunately, this statement does not apply in the context of pregnancy, and we'll talk a little bit about why. But thinking about breastfeeding in particular, as I know Annette Haber will speak to you about pregnancy, we know that decisions about the risks and benefits of breastfeeding can be very complex for women. People talk about the bonding of breastfeeding being important. They talk about breast is best, and that a bottle feed may mean that a baby does not receive some important nutrients, but also antibodies from mother. There's also worries about when somebody is taking antiretroviral therapy that there may be issues regarding their adherence to their ART, but also the toxicity of ART that may be in breast milk given to the baby. And we know that the risk from breastfeeding is not zero with regards to HIV transmission. And this is something we'll talk a little bit more about. But also there is a cultural intersection, certainly we see in particular groups of patients where to not breastfeed can be a high risk of disclosing HIV status, particularly to family and friends who may come from populations where HIV is very prevalent. So all of these issues really put significant stress on a woman or a person who is pregnant with HIV when deciding about breastfeeding. And it's often important for people to be prepared to have a socially acceptable reason as to why they may not be breastfeeding. And so we will have discussions with our patients about milk not coming down, about baby not being able to suckle properly, or potentially there being an infection called mastitis in the breast, requiring antibiotics, and to create a story around this. But for some people, it may be a personal reason. Not all people want to breastfeed anyway, whether they have HIV or not. And by not breastfeeding, it does allow the partner to also bond with the baby by doing bottle feeding and sharing those night shifts. But thinking about the basic principles of HIV in pregnancy, let's go back to the history of why how we learned breastfeeding could be a risk for transmission. So if we start in 1992, we realized that there was an additional risk of HIV transmission, with a 14% risk of transmission reported in women with HIV who were breastfeeding in Nigeria. Then in 1999, it emerged that actually if babies were exclusively breastfed only, you could reduce HIV risk. Then in 2001, it was suggested that formula feeding be the best way for women living with HIV to feed their babies to avoid transmission. Then in 2005, bottle feeding became the recommended preferred option for women with HIV to feed their babies. But in 2007, there were high death rates in infants born to women living with HIV due to diarrheal illness, which was investigated. It was found that this was due to lack of formula feed availability. And in 2008, WHO revised their guidelines to suggest that breastfeeding be recommended in women on treatment to avoid excess mortality. That was being seen where formula feed was being recommended. So an example of what may be applicable in high-income countries not being applicable globally. So if we look at what's happening in the UK, we know that most women are actually diagnosed with HIV prior to delivery. Therefore, we have a chance to talk about all of this evidence with women. So what's happening in high-income countries with regards to guidelines? So I guess we can say, particularly in the UK, that we were leaders really in the context of this. So in 2010, we first issued a statement where breastfeeding had been contraindicated in women living with HIV. We stated that actually where women had a viral load which was undetectable, women could be supported to breastfeed in this context, as long as there was additional monitoring of both mother and baby whilst she remained on treatment for the duration of breastfeeding. And this is the full statement, which is available on our website. Before this, if a woman were to breastfeed, she needed to be reported to social services to try and invoke child protection. But this, in 2010, given the new evidence, showed that actually this was draconian and not required any further. And the evidence that this was based on was the Mabana study, the BAN study, as well as other studies, which showed that actually the transmission risk was far lower than that initial report in 1992 of about 1 to 5% where mother or baby was given ART cover. And this was the first data that we had emerging from the developing world, so lower middle income countries, on breastfeeding and HIV. In 2012, we incorporated this statement into our guidelines and suggested that women be supported to breastfeed with an undetectable viral load for a maximum of 6 months. In 2016, the majority of high-income countries remained unsupportive of breastfeeding in their guidelines. And in 2017, EACS changed their guidelines and updated it to allow breastfeeding, but language was quite stigmatizing, suggesting that it was only if the woman insists. And this was all part of the journey for all of the high-income country guidelines. So given that in the developing world and WHO recommendations were to breastfeed with antiviral cover, why were the recommendations in high-income countries so different? And really the balance came from the benefit of, from trying to find the balance of benefit versus harm, and suggesting that in low-income settings, it was potentially different because of unclean water, loss of protection of maternal antibodies in breast milk, which were very valuable for other infections which could be endemically prevalent there, but also the lack of availability of the formula feed. And that goes back to that 2007 high mortality in infants that I referred to previously. So it suggests that although we were all looking at the same data, because of situational differences in high versus low and middle income countries, guidelines remained very, very different. So in 2018, the US guidelines suggest that there be an evidence-based discussion with women living with HIV to talk about breastfeeding. And the guidelines I chaired in 2018 for BEVA, we continue to support choice where women were virologically suppressed. But in 2025, no guidelines in high-income countries recommend breastfeeding first line. So these are the US guidelines that were promoted at CROI 2023. The WHO guidelines on infant feeding in 2015 continued to suggest breastfeeding be supported in women on antiretroviral therapy for 12 to 24 months, that the risk of transmission was low, and this was reiterated in the 2023 WHO recommendations, where again 2 years is the guidelines suggested. So what is the data we are currently looking at in the context of HIV? Well, it's actually quite old in the scheme of things. So we are currently basing things on the PROMISE study, where the risk of transmission was 0.3% at 6 months, and the risk of transmission was 0.6% at 12 months of breastfeeding. And so this is where BEVA came up with their guidance about stopping at 6 months, because although the risk is quite low in both groups, it doubles from 6 to 12 months. But this is over 10 years old. And this slide, what I really want to draw your attention to is that actually a lot of the data comes before we had good HIV treatment. And when you look at exclusive breastfeeding versus exclusive mixing only with formula, the risk is pretty similar. And so we have really changed our guidance this year and our new guidance that is coming out, because the biggest issue is if you introduce solids whilst still breastfeeding, that is where the most risk occurs in the context of HIV transmission. So the advice would be to stop breastfeeding before starting solids and convert to formula feed, and only introduce solids once this has been successfully achieved. And so if we look at the UK, where supported breastfeeding has been happening, and we have over 267 reports of breastfeeding, you can see that although there is still some data lag in reporting, we have had no new transmissions of HIV in our infants, and you can see that our vertical transmission rate remains very low, even though breastfeeding has been occurring in small numbers in the UK. And why women want to breastfeed is for those reasons we talked about earlier. So bonding, health benefits, family and friend expectations really, really high up there, and disclosure concerns. So really significant reasons that still persist even in 2019. And if a woman does not want to breastfeed, it can be very uncomfortable, so we do recommend providing cabergoline, a one-off dose within 24 hours of delivery, so we switch off lactation and makes things more comfortable for the woman, but also means that she can't breastfeed, so you must ensure that she's very happy with that decision. Just thinking then about postnatal prophylaxis, because this is what I always get asked about. If a woman is breastfeeding, do you need to increase the length of duration of postnatal prophylaxis? The answer is no. So if a woman is low risk enough to be breastfeeding, we continue only postnatal prophylaxis for the 2 weeks for all women, whether they are breastfeeding or not. It does not need to be extended. We do our HIV testing in the infant not only at the 0, 6, and 12 weeks, but we extend that for the duration of breastfeeding until after breastfeeding has stopped. And we have very clear updates in our guideline, in our website from 2022-23, talking about all of this. So I'm just going to flick through this now. You can see we've got information for parents as well. And clear communication really and discussion with parents before delivery is the most important thing. But this is available online. If you want to download it, translate it, use it in your clinics, you are very, very welcome to. That is why it is there. And BEVA would really encourage you to do this. I'm part of a group called Inform Plus, where looking globally, there is inequity for all women. So in high income versus low income countries, we are doing really extremely different things. And what we need to do is meet in the middle based on evidence and actually give equal care for women globally living with HIV. Also, I want to draw your attention to the fact that peer mentoring is incredibly important, and also women report that this is one of the most positive things that they can do when they are thinking about breastfeeding, is to talk to other women who may or may not have breastfeed, and to just have that peer mentoring conversation. So if that's something that you can facilitate in your clinics, I'd highly recommend it. As I said, our BEVA guidelines are being updated. They should be out within the next few weeks, and we have really improved our section on infant feeding. It's more in line with our infant feeding update from a statement from 2022, and also we have more data on dolutegravir as well. But I'm going to finish on language and how language must be inclusive. So where our data only talks about women, it is because the evidence comes from women-only populations. But there are other populations of pregnant people who do not self-describe as women, who must be included, which is why I've talked about breast and chest feeding. We're the first guideline to do it, and I would urge you to consider that as well. So in summary, for HIV and breast chest feeding, the decisions regarding breastfeeding can be very complex. And so it's important to take that time ahead of delivery to talk about it with women. We have a growing evidence base of both qualitative and quantitative data, but we still have many unanswered questions, as U equals U does not apply. Guidelines and recommendations are not consistent and are continuing to evolve. So an early informed discussion between healthcare providers and peers with each individual who's pregnant is very, very important. And watch this space for our new BEVA guidelines, which we know are internationally very well reviewed, and urge you to look out for those coming soon. Thank you very much for listening.
Yeah, thank you so much, Yvonne. I don't know if Yvonne had the chance to join us for discussion. Sergey? Not yet.
Здається, що поки що ні. Тому
Ще ні.
просимо Анет,
Not yet. It looks like not yet.
будемо відповідати.
So
Yep.
maybe we will all try to answer questions, and we rely on you very much in that, indeed.
Yeah, but it was such an excellent presentation. So based on that, we can start our discussion. And if I may start first, you can clearly see differences between the BEVA guidelines and the revised German-Austrian guidelines. So in terms of neonatal prophylaxis, even in terms of monitoring during breastfeeding, also very strict conditions in the UK, even though they have a little more experience with breastfeeding. Look at the numbers, more than 200 cases reported to ISOS than we have in Germany. Anyway, I think UK as well as Germany, or no, not Austria, but Switzerland, we started way back making breastfeeding experiences, and based on that, and based on a lot more data coming from the Western world in terms of HIV and breastfeeding, we are now looking forward to make recommendations that make it feasible for all people living with HIV who fulfill certain criteria to choose to breastfeed or choose to formula feed. As I said in my presentation, we should not put any pressure. Now you fulfill the criteria for breastfeeding. Now you should breastfeed. That's a very personal decision. And we should respect it, also respect it in an interdisciplinary team. Because what I have to say, to my experience, if we as HIV specialists say, okay, if you want to choose breastfeeding, go ahead and do so. We make a plan for the monitoring. It does not mean, even in the same clinic, that the pediatrician or that the obstetrician really is on the same side. So sometimes women changed their decision after they talk to the pediatric colleague or to the obstetrician. We now manage in our clinic to have it as an interdisciplinary, to manage it as an interdisciplinary team. So if a woman decides to breastfeed and the decision is clear before she delivers, she will breastfeed unless she changes her mind by herself, but not based on the counseling of another discipline. So we are pretty clear with that, but that is an experience we made in the beginning. So it was not accepted in the same way by all the disciplines, even not by the midwives or some nurses. So we have to guarantee that a decision, once it's made, is respected by the whole team.
Дякую, Анет.
Thank you very
В нас
much,
є
Annette.
доволі багато запитань у
Well,
чаті.
actually, we have quite a lot of questions in our chat. For
Наступне
example,
запитання. При
like this
якому
one,
вірусному навантаженні
in
у
which
жінки ви
values of
припиняєте
viral load in a
виробляти?
woman you stop breastfeeding?
Well, if there is a blip, we just interrupt. We don't stop or we restart. But to confirm that it's a blip, a very low viral load, but above 50, we have to check it immediately. So if we see something like that, and we had a couple of cases that made us worry, we call the woman and tell her we want to check it again, maybe the next day or in 2 or 3 days. And until then, she should take the milk from her fridge. We always recommend to put some milk in the fridge for these cases, and not use the milk from the breast. And in all our cases, then it was not a confirmed increase of viral load. It was really just a blip. But until you confirm it and you check the lab result, you are really getting nervous. So we do have it in our guidelines now that if there is an increase, of course, a low increase of the viral load, you have to immediately check the viral load again. And if you confirm it that it's still increasing, you stop breastfeeding and you think about post-exposure prophylaxis. But if it's a blip, you do nothing, you just continue breastfeeding. But for these situations, it's so important to counsel the woman and to have a midwife on the side telling her that how to store milk in the fridge, to have it for situations like that, and also for mastitis, to do the right counseling. There's so many different situations during a breastfeeding period. You really need specialists for breastfeeding on your side, and these are not only gynecologists, obstetricians, also midwives are really important. So in our guidelines, we recommend having a midwife for every woman living with HIV who delivers a baby, breastfeeding or not breastfeeding. But for breastfeeding, it's extremely important.
Дуже дякую, Анет.
Thank you very much,
Дійсно,
Annette.
дуже хороша відповідь. Спасибі вам велике.
Truly, it's a
В
wonderful
нас є
answer. Thank you so much. And
декілька
also, we
запитань,
have a couple of
пов'язаних
more questions related
з ПКП, з післяконтактною
with
профілактикою.
PEP,
Перший
post-exposure
з них
prophylaxis,
ця
and
серія в нас.
one of them, the whole
Якщо
series
дитина
of
на
those. So the
грудному
first one,
вигодовуванні,
if a
то
baby is
чи
on
отримує вона
breastfeeding, so whether the
післяконтактну
baby is
профілактику?
getting a post-exposure prophylaxis.
No. If the mother is fully suppressed, and that's one condition for breastfeeding, like Yvonne also said, but Yvonne said in the UK, you will do 2 weeks of post-exposure prophylaxis. In Germany, as well in Switzerland, we don't do it because no risk, no prophylaxis. If the maternal viral load is fully suppressed, no prophylaxis, and breastfeeding doesn't change a thing.
Супер,
Right,
супер.
wonderful, super, super.
І наступні запитання вони
And
By the way,
next
may I-
questions.
Sorry, if I may add, we had a professor, a pediatrician from Switzerland last week at our meeting, and he said it has never been proven that you really have a positive effect of the neonatal prophylaxis. It was just added, but there has not been a single study showing the single or unique effect of that. You know, it's always, this mixture or this combination of prophylaxis. And so it was added because of the ACT study, the early one, because it was done there. You carried it on. But it has never been studied. So the pediatrician just said, no, it does not make sense. Of course, a pediatrician from Switzerland, but that makes no difference. I thought it's extremely interesting that a person from this discipline says it does not make sense. If we say it as HIV specialists for adults, they are laughing at us. Yeah, you are not a pediatrician. You don't take care of the kids. But the pediatrician himself said, no, it has never been proven. So.
Дуже дякую,
Так,
Анет.
це
Тобто,
правда.
Thank you very
тобто
much,
на
Annette.
першому
So,
місці
in
це
other
вірусна
words,
навантаження,
number one is viral load.
а
That's
не
something that we
грудне
consider,
вигодовування.
and we are
Так,
not
якщо вірусне
talking about
навантаження
breastfeeding
незначного
first place.
рівня,
So, if
менше ніж
viral load
50 фото,
is
то і
undetectable, less than
профілактики
50
немає.
copies, then
Я
no
думаю, що
prophylaxis.
Галина Васильівна,
Yeah.
ви
And I think
краще вам це
Galina then would
сподобається, мені
probably
здається,
mention
тому
later
що ви
whether she likes
завжди
that or
турбуєтесь
she
про
does not,
те,
because you
як
always
антиретровірусні
worry, Galina,
засоби
with regards
впливати на
to
дитину. Так?
ARVs and their impact on a baby, right?
Yeah.
Можете включити мікрофон,
And
сказати.
So
also-
you might turn your mic on maybe to say if you would like to say something. That's right. Yes, I agree with you. That's true.
Дякую.
Thank you.
Отже, у нас є ще
Okay.
буквально одне запитання.
Well, maybe one more
Виходити-
question.
Так, прошу.
Анет, дай слово.
Welcome, Annette. Yes, please.
Yeah, well, I'd just like to get back to this mixed feeding thing, and there was an elevated risk of vertical transmission based on mixed feeding when the maternal viral load was detectable. So all this data come from the old days, and even from the PROMISE trial. I mean, we have to remember only 40% of the women were virologically suppressed when they started breastfeeding. Only 40%. So the majority had a detectable viral load, and still the vertical transmission rate was that low. After 6 months, 0.3%. After 12 months, 0.6%, and it doesn't increase then if you continue breastfeeding. So we can easily imagine with our modern drugs, we will have better results. And again, to cite the pediatrician from our meeting, he said, well, even though you would see one transmission during breastfeeding in all the breastfeeding infants here in Germany, in Austria, across Europe, is that a reason to constrain all the other kids from the benefits of breastfeeding? Would we do that in a context? So again, the pediatrician is in favor of breastfeeding if U equals U, as far as we know today, does not apply to this setting. So it's really interesting. And this formula feeding, once again, so it's mixed feeding. So the introduction of solids, we have it in our guidelines, not before month 4. Actually, it's 4 to 6 months, like in any other baby. You would not give a bread or a sandwich to a 2-week-old baby. It does not make sense. So again, back to normal. So the introduction of solids, the same as in any other infant, but you can, what sometimes is also called mixed feeding, you can use formula feeding in addition to breastfeeding. For example, in situations when you have a blip and you don't have stored breast milk in the fridge, you can use formula feeding, or in any other situation when it does not work, or mastitis or whatever, you can use formula feeding. That is nothing that will increase the risk of transmission. So we have to be clear in our definitions. Solids, that is a different thing, and that is what we usually call mixed feeding when we talk about it. But it's also mixed feeding to introduce or to use formula feeding, and that is not a problem at all. So it's easier than we think once we make our experiences with breastfeeding.
Так, дякую, Анет. Я якраз і хотів
Right,
повернутися
thank
до
you.
нашого
That's I really wanted to get back to that mixed feeding question, but thank you for reminding me of that. So colleagues, in this case, let us move on, and this is going to be our third mini lecture for today, on track to eliminating vertical HIV transmission in Ukraine 2025, delivered by Olena Strazhak. You're most welcome.
Greetings to everyone. My name is Olena Strazhak, and I represent charitable organization Positive Women. It's a national community of women living with HIV in Ukraine. And I would like to share today our achievements and challenges that we have here in Ukraine on track to eliminate vertical HIV transmission. No conflict of interest. First of all, I would like to mention that 3 years ago, on April 26, 2022, in Ukraine, certain changes took place, including with regards to regulations in the field of HIV vertical transmission prevention. It's the clinical guideline, mother-to-child HIV transmission prevention, healthcare standards, mother-to-child HIV transmission prevention, approved by the MOH Ukraine Order 692, and updates scheduled for next year. And the clinical guideline was developed by adapting documents describing key current approaches in the field of HIV vertical transmission prevention and maternal and child health support. So the specifics of the regional guidelines were taken into consideration. Assessments was agreed to instrument, and the working group was chosen prototypes of specialized organizations and associations like World Health Organization, PIVA, Office of the U.S. AIDS Advisory Council. So in accordance with the standards, service providers are OBGYNs, neonatologists, general practitioners, infectious disease specialists, pediatricians, doctors from healthcare facilities and institutions providing care to patients with HIV, midwives and nurses. How the healthcare standards were developed? First, representatives of community of women living with HIV were involved to co-author, and some women could share their personal experience, and there were full-fledged participants to the working process of the development. And also, these standards included broad integration psychosocial issues, psychosocial support for HIV and pregnancy. For example, it is recommended now to offer peer-to-peer support to pregnant women living with HIV because it's the most efficient with this type of services provided. Also, screening for sexual health is taken into consideration. Also, mental health assessment and support. And there is screening with regards to substances used by women with regards to and with help of assist guideline. Also, risk assessment for domestic violence was included into the list, and it shows that this complexity includes not only monitoring the physical health, but more monitoring of mental health is included. The environment is taken into consideration, which is really very important with such a comprehensive approach and assessment, starting from pregnancy planning, pregnancy itself, labor and delivery, case management follow-up after delivery, and also with regards to the baby's health. Also, in the new standards, we have the opportunity to provide a woman the opportunity to choose. In other words, it's her decision with regards to feeding the baby. So a woman can choose breastfeeding, for example. Also, together with formula feeding can be chosen, and that helps a lot when a woman is choosing, for example, what she really wants. She can have that feeling that it's up to her, but that is possible only when all the information is provided with regards to HIV, viral suppression, ART, adherence to ART. So when we counsel and when the type of feeding is selected, we have to inform about the low risk of HIV transmission with breast milk in this situation and recommend additional clinical and laboratory monitoring for mother and baby. On this slide, you can see the key indicators of program for prevention mother-to-child transmission in Ukraine. You can see the last 3 years are given in comparison, and early detection data, for example, shows us that we reached the target indicators, even the decrease of this rate, and we have reached less than 2% recommended by WHO. And the next line is the cohort analysis data. So based on cohort analysis data, we can see that in 2024, when we collected data with regards to children born back in 2022, we can see 2.4% that shows us the maintenance. We have reached the target indicator and it is maintained, but this rate might change, and it is changing a little bit, but our ultimate goal is down to zero, because the ultimate goal is HIV transmission elimination. So we are doing and will be doing everything possible to make it as low as possible. And also you can see the sustainability trend with regards to pregnant women coverage with ART, and you can see it's more than 95%, and there is increase compared to 22 and 23. It's higher than the target indicator, so coverage with ART is quite high. Then pregnant women coverage with viral load testing, you can see a bit lower compared to 2023, and the target indicator, unfortunately, is not reached. But that is related to the challenges that we have today. This is lack of funding today, and the main challenge is the fact that a woman cannot always get to the healthcare facility in order to undergo relevant testing. So it's difficult for women to travel and get to healthcare facilities. So that is why this target indicator has not yet been reached. And also HIV-exposed babies coverage with early detection. with the help of PCR testing. You can see this rate, this indicator is quite high. It's quite sustainable, and it's higher compared to previous years. HIV-exposed babies coverage with post-exposure prevention a bit lower compared to the previous year, 2023, but actually there is sustainability here as well. So it's kind of maintained, this result is maintained, but we need to still reach 100% according to target indicator. HIV-exposed babies coverage with pneumocystic pneumonia prophylaxis, PCP prophylaxis for 2 months from birth is a bit decreased compared to the previous year. First of all, it's related to the problems of traveling, the possibility to physically get to healthcare facilities and getting relevant medications free of charge if they are there, and also due to lack of funding and due to some problems with regards to providing necessary treatment to children. This indicator is a little bit lower as well. What other information, knowledge, experience that we have received and obtained over those 3 years after the clinical standards and the clinical guideline has been implemented? We can say that the counseling that is done by the healthcare community together with civil communities, together with communities of women living with HIV are done. So thanks to this work in a multidisciplinary team and this comprehensive approach, we can say that the counseling on safe breeding includes informing about possible HIV transmission with breast milk, explaining pros and cons of formula feeding or breastfeeding on ART, discussing individual family circumstances and option to implement formula feeding, discussing living conditions, access to drinking water and possibility to cook foods, accessing ability to prepare formula following hygiene requirements, helping to make informed choice regarding baby feeding based on personal circumstances and conditions for priority formula feeding, providing written baby feeding prescription, developing practical baby feeding skills, informing about the procedure for free of charge receipt of breast milk substitutes. And the next slide is showing the numbers, the indicators that we have with regards to feeding of HIV-exposed babies. As you can see, compared to previous years, last year, women living with HIV have given birth to 1,125 babies. It's 105 babies less compared to babies born in 2023, and in 22 it was 1,423 babies. So the trend is towards decrease, but still this number in general is quite high considering all the complexities, difficulties, the demographic crisis, population migration that we have currently in our country. So considering how many babies were born on exclusively formula feeding, we have the majority of them, 99.6% of babies on formula feeding. On mixed feeding, and for us it's more dangerous, we can see that in 2022 in Chernihiv Oblast there was 1 baby. For that baby, mixed type of feeding was applied, was used. Then switch from breastfeeding to formula feeding. So that's when a woman starts to breastfeed right after delivery, and then she switches to formula feeding. So in 22, those were 9 babies like that. And the oblasts or regions are mentioned here. In 23, it was 2 babies. And in 24, also 2 babies. That means that still there is a trend for some reason start to breastfeed, and then they switched over to formula feeding. And later on, I will share the conclusions and thoughts why it's happening. But although the number's not quite, but still it's present. So the mixed and switch from breastfeeding to formula is there. So we have that. And we can see that over the last 3 years, like in 22, it was 2 babies in Dnipropetrovsk Oblast, 2 babies in Dnipropetrovsk, Chernihiv Oblast in 23 that were on breastfeeding. Also in 2024, it was 1 baby in the city of Kiev on breastfeeding. So this is with regards to limitations regarding breastfeeding by women living with HIV in Ukraine. Late ART initiation or poor adherence to treatment. 21% of newly diagnosed pregnant women with HIV learn about their HIV status in the 3rd trimester of pregnancy or during labor and delivery. Low awareness of mothers regarding types of feeding. Women do not always get complete and clear information about benefits, risks, and rules of breastfeeding or alternative feeding. Stigma and discrimination, that was I mentioned when I was talking in the previous slide. The fear before the disclosure actually prevents a woman from making correct choice regarding baby feeding. Sometimes when a woman has this opportunity to get formula feeding, she needs to go to the local government authorities, and that mechanism is different in different oblasts. And this fear of HIV disclosure, when a woman needs to go there to get formula, can be a barrier for a woman to make the correct choice. And also the type of formula sometimes, the choice of different types of formula sometimes is limited, and sometimes the available formulas are not high quality. So sometimes there is difficult to choose from what is available. For example, sometimes hypoallergic formulas are not there, not included in that list. So sometimes it's a real choice for a woman. When there is not a formula that the baby requires, then there might be breastfeeding chosen. So stigma and discrimination is quite high, and it is really a serious barrier for a woman. So counseling, case management, comprehensive approach should be applied and used. The whole team should be working. Referral mechanisms should be applied, and that will help a woman to make a good choice. Low accessibility or high cost of breast milk substitutes. In many regions, there is free of charge formulas provided to women, but not always. There are some oblasts or regions or communities where money is not allocated for that. And our community of women living with HIV is advocating for allocating money from local budgets in order for the local budgets or local authorities to be able to procure breast milk substitutes for women in order to provide that to babies and cover babies born to mothers with HIV. But it does not always work in the correct way, or the money that's allocated for that is not enough. So we try to involve international funding also and other sources in order to cover the need that we have now. Lack of support on part of healthcare workers. Healthcare workers might have insufficient knowledge or controversial strategies of counseling mothers regarding baby feeding. So a decision that has to be made by a woman is based on several steps. So the complete information needs to be provided, first of all, in order for her to be able to make the correct choice and what type of feeding she needs to use. Thank you for your attention.
Пані Олена, щиро дякую за дійсно чудову.
Ms. Elena, thank you really very much for a really wonderful presentation and lecture. Yeah, once again, we would like to express our gratitude to you for you being with us
реабілітації,
today,
де і не
because
лише насправді до
multidisciplinary
операції, взагалі
approach is
професійному
very
розвитку,
important
якісної
for
медичної
HIV,
допомоги,
and not only for
якісного
HIV, in healthcare in
життя
general.
наших
It's
пацієнтів.
the
Тому
the
дійсно це
basics
вкрай
for
важливо
everyone,
саме таке
for
поєднання
every
професійної думки лікаря і
specialty.
представниць
So this combination of a
спільноти на даному випадку.
professional
Щиро вам дякую. Є
doctors'
одне, що
views
я
and
хотів ще запитатися. У
community
нас є в чаті
representatives is
декілька
important.
запитань, але вони
And
скоріше
we have a
для
couple of questions in our
всіх
chat,
наших
but they
спікерів з
seem to be
України.
relevant
Чи не
for
будете
all
дозволити,
our
якщо може
speakers
швидко
from
проігнорити
Ukraine, if you
клінічний
don't
випадок?
mind. So
Далі
maybe
обговоримо
if we
запитання
will
до
look
вас
at the
та Галини
clinical
Васильівни,
case
саме
first, and then we
двох
will put
представниць
questions to you and Galina
спільноти інвалідів
as
Львів
community
і як
representatives,
представниці медичної
as
спільноти, які
representing
надають допомогу.
also both community and doctors who provide care to HIV. Of course, Sergey, no problem. The only thing that I would like you, Sergey, not to forget to give me opportunity to say something. Already after my presentation, I already have something to add on top of that.
Спасибі, Олена, за
Yeah,
вашу акцентацію.
actually,
Це
I
дуже
agree.
чудово.
Thank you,
І
dear Olena, for your
бачите, майна
advocacy.
дуже грошей
Thank you
мало,
for
але
advocating,
все ж
supporting
таки в місцевих
women,
бюджетів
regardless
ці
of war.
суміші можете
We don't have a lot
доставати
of money, but
рівневий,
still you are
тому
trying
без
and you are getting
ніякої
local
іншої
budgets money.
опції,
If it was
ніж
not for you, we wouldn't
годувати
have
дитину.
any other option,
Вибору не
just
було, тому що
breastfeeding,
держава на сьогодні не може
But in
забезпечити,
this
на жаль,
case, yeah, you are doing everything possible,
повнообсяжний
because
і так
on a
не
national level, it's not
не дуже
possible to
важкі
provide
часи.
women
Ну
with
що, Галину Васильівну
formula
будемо
feeding in the full scope.
слухати,
So
а
we
потім
will be
обов'язково
hearing
надамо вам, Олена,
from
слово.
Galina, and
Сергій,
then we will
бачиш,
give the
як
floor to you, Olena, as
строго
well.
за часом.
Okay.
Так,
So it's Sergey, you are a
ви можете
timekeeper, so
вимушені
please.
слідкувати за
Yes,
часом.
I
Так.
need to do that. I'm a
Отже, зараз
timekeeper.
тоді ми
So
переходимо до
right
представлення
now,
клінічного випадку
it's
ВІЛ та
the
грудне
case that's going to
вигодовування
be
в
presented
Україні.
HIV and
За і
breastfeeding in
проти,
Ukraine,
який
pros and
нам
cons,
представить
and it's
Галина
going to be
Шерстюк. Пані
presented
Галино, будь
by
ласка.
Ms. Galina Sherstyuk.
Good afternoon, distinguished speakers, fellows, colleagues, organizers, and everyone who has contributed to this event. The topic of my report is breastfeeding in Ukraine. Cons and pros. There is no conflict of interest. The possibility of safe breastfeeding of babies born to mothers living with HIV is closely related to measures implemented in the country related to prevention of vertical HIV transmission. According to the Center for Public Health of Ukraine, 99.7% of pregnant women visited a gynecologist at an antenatal care facility at least once during pregnancy. 98.3% of them underwent HIV testing, 97.3% HIV positive pregnant women received ART during pregnancy, and 95% of them had viral load testing before delivery to determine the mode and strategy of delivery and implement vertical transmission prevention measures to the baby. The coverage of HIV-exposed newborns with antiretroviral prophylaxis was 99.4%. Efficacy of ART in women during pregnancy, and this is data for 2023, but this trend still exists. So 78.8% of pregnant women had successful ART at the time of delivery. Their plasma viral load was less than 50 RNA copies per milliliter. Unfortunately, in 11.5% of women, the HIV viral load before delivery was more than 400 copies. Current data on HIV vertical transmission rates by regions according to the results of PCR of HIV proviral DNA. HIV vertical transmission rate in Ukraine for 6 months of 2024 was 0.8%. In 19 regions of Ukraine, this rate was 0, and in 4 regions, one positive baby was born in each of those 4 oblasts. But due to the small number of deliveries, this rate increased from was different, 1.5% in Dnipropetrovsk region to 5.5 in Kirovohrad region. And these were women who did not receive ART, and the reasons were refusal from treatment or HIV positive status determined already during delivery. More than 99 HIV-exposed babies in Ukraine receive formula feeding. Each year, only a few babies are breastfed, and in recent years, there have been no HIV-positive babies among them. 58% receive adapted milk formulas at the expense of local budgets, a quarter at the expense of humanitarian aid, and about 20% it's out-of-pocket family money. Safe breastfeeding in Ukraine is possible due to the high level of ART coverage of pregnant women living with HIV, high efficacy of ART during pregnancy, high rates of coverage of babies born to women living with HIV with post-exposure prophylaxis, and since 2022, regulatory documents along with the regulation on formula feeding of babies born to women living with HIV provide the opportunity to breastfeed these babies if this feeding is safe. Breastfeeding has absolute benefits not only for the child but also for the mother. Breastfeeding is inherent in women and a natural way. It's naturally the safest way to give a baby what they need for their physical, mental, and emotional development. Human milk contains the necessary nutrients, vitamins, and minerals, as well as antibodies, protecting the baby from infections. What are benefits for mothers? It's decreased postpartum bleeding, and due to contraction of muscles of uterus, decreased risk of postpartum depression. Breastfeeding enhances bonding. Breastfeeding as contraceptive method in the first 6 months of baby's life, probability to get pregnant constitutes only 2% for those who breastfeed. Subsequently, those who breastfeed have lower risk of breast and ovarian cancer. And this is a case, a practical situation that one family had difficulties with because the baby had developed allergy to cow's milk protein. Matvey was born on the 30th of March 25, first pregnancy at 39 weeks, natural delivery, and the body weight was 3.5 kilograms, APGAR score 8 and 9, mother is 19, mode of transmission vertical, discordant couple, and baby's father HIV negative. The mother takes ART since she was 9 years of age, and during all this time her viral load was less than 40 RNA copies. At 36 weeks of pregnancy, her CD4 was 457 cells, 25%, viral load less than 40 copies per milliliter. At day 3 of life, the baby had the nucleic acid testing done by dry blood spot, HIV DNA negative, and the baby is on formula feeding, and mother's lactation was medically stopped at a maternity ward. And since 10 days of life, according to the mother, the baby developed rash on face, neck, trunk, signs of impaired digestion, bloating, constipation. The boy has become irritable, almost stopped sleeping. Half an hour after feeding, usually woke up and cried himself blue in the face, tried to eat again, cried again, was admitted to pediatric hospital, evaluated, no organic pathology found. It was recommended to switch to a lactose-free formula, use probiotics, glycerin, suppositories, simethicone drops, abdominal massage. At home, baby's condition did not improve, and before he turned 1 month of age, he was switched by doctors from one formula to another 5 times. And now he gets formula with complete protein hydrolysis. His behavior has improved. He calmed down, is gaining weight, but the rash is still there, and that makes the baby irritable. Unfortunately, cases of allergy on formula feeding happen not infrequently, and when formulas are not purchased from local budgets, feeding a baby becomes a heavy financial burden for baby's parents. So the question is, would it be possible to recommend breastfeeding to Matvey, and would it have been safe? And the answer, probably yes. So there are quite a lot of women living with HIV with a successful ART history and treatment efficacy in Ukraine. Why then formula feeding is a priority? What are the barriers in order for HIV-exposed babies to be breastfed? So this is uncertainty by doctors. They are not able to answer difficult questions. For example, when breastfeeding babies born to mothers living with HIV, what is more prevalent? So what do we have more, benefits or risks? And does undetectable plasma HIV viral load ensure safety of breast milk? What is the concentration of ARVs, mother's ARVs in breast milk? How can that impact the baby? For example, how TDF may impact kidneys or baby's bones. It is known that mixed feeding is not recommended as it increases HIV vertical transmission risk. But what to do when the volume of breast milk is insufficient? What's the duration of breastfeeding? So is supplemental feeding okay with breastfeeding? If a woman starts breastfeeding immediately, what to do in case of positive nucleic acid test results at day 3 of life? How should the baby be switched to formula feeding in this scenario? Formula feeding is one of the components of HIV vertical transmission prevention with proven efficacy. So do we need to change anything? Also, we know about the complexity of routine laboratory monitoring to support mothers and babies on breastfeeding. It's monthly testing of mothers and babies, but that's difficult to do and to follow in peaceful times and almost impossible now in these difficult times. Vertical transmission prevention is a dynamic and significant approach in eliminating HIV epidemic in Ukraine. Achievements in this field allow to use safe breastfeeding of HIV-exposed babies wider and better, and we hope that experience presented by our colleagues at this event will allow us to overcome doubts and make correct decisions regarding breastfeeding to benefit mothers and babies. Thank you for your attention.
Dear Galina, thank you really so much for your wonderful, wonderful presentation. You've been working for so many years in the area of HIV infection, helping babies. For how many years you have been
З
working?
2005 року я працюю з ВІЛ-позитивними дітьми. 20 років.
Ну, то,
30
20
years,
років. Тому я думаю, що ви могли
which is 20 years. I'm sorry for this.
дуже
I'm
багато
sorry. So
інших
30 years in
ситуацій.
general with
І
HIV
дуже дякую
positive
вам за
for
те, що ви
20 years. So
прийняли
thank you
участь.
very
Я
much for
думаю, що ви ще так
participating.
хвилювалися
And
трошечки.
probably you were a little bit nervous, but that's okay. We are going to invite you more and more. So you'll get used to that. You will
І хочу
not be
сказати,
as
що чудовий клінічний
and
випадок.
I need to tell you that was a wonderful clinical case. Can you tell me, please? So you've heard Annette, you've heard from the head of British HIV Association. Can you tell me, have you found any answers to your questions that
Ну, сумнівів стало
maybe
менше.
concerned you?
Я думаю,
Well,
що
maybe
якщо
now I
можна
have
було б
less
повернути
doubts.
Матвію в роки
If
його
I
дорожні, то я б
could
його повернула з радістю.
bring Matvey, our
Це буде
little boy, back onto breastfeeding, I would
і наука, і
gladly do that. So this is going to be
будемо
wonderful for
сподіватися, що
future.
ми
We
покращимо
will
кількість,
base our work on the current experience, so
матерям
we will be
вибору,
able
будемо їх
to
супроводжувати,
give
будемо їх консультувати.
mothers much more choice. We will
Як ви
support
любите
them,
своїх
counsel them.
пацієнток. Я
I
знаю,
really
що
know
оця
how you
у цьому
love your
клінічному випадку
patient.
це ж
And in this
це ж
clinical case,
пацієнтка,
actually, I
яка
know that's
народилася, так?
the
Вона
patient
була експонована
who
ВІЛ,
was
і вона була
born
лікувана,
HIV
і вона вже народила дитину. Бачите, і ви кажете, що
infected.
може
Okay, and
краще їй
now
було
that
груддю
patient gave birth
годувати. Це
to
дуже-дуже
to
важливо.
her baby,
Бо
so it
що
was
я
important for her to
услышала,
breastfeed.
що
And also what I
незважаючи на
heard that
війну, на те,
regardless
що багато
of
жінок
war,
уїхало, ну,
regardless
все ж таки
the fact that
людей,
many
понад 1000
women
дітей
have
народили
left
за
the
рік.
country, but still more than
Наші
1,000
жінки,
babies
які
were
живуть з
born by
ВІЛ-інфекцією.
our
Звичайно,
women living with HIV
ці
here
питання
in Ukraine.
дуже
So
актуальні
these
для нас.
issues are
Дуже
really
дякую.
relevant to us. So
Дуже
thank you
дякую,
really
Васильівна.
once again,
А,
dear
Сергій,
Galina. And
ми ж не задали питання Олені.
Sergey, how about Elena's question?
Так, у нас є ще коментар від Анети. Я
Yeah,
думаю,
we
одразу
have a
після
comment
цього
from
надамо
Annette, and
мікрофон
probably from
пані Олені.
Annette's comment, we will give the floor to Olena.
Олена, скажи, як завжди, активістам, ну, останні слова запам'ятовуються.
So yes, the last word is going to be from activists.
Yeah, Svetlana, I know we are short of time, but I have to say I'm so deeply touched and impressed by the last two talks. You have to struggle with so many challenges in Ukraine. I can't imagine how you still find energy to be on track, to keep things going, to improve the situation for women living with HIV and for their infants. And I have to say that I don't know where you get the energy from, what keeps your motivation high, but from a person sitting here in a peaceful and quiet surrounding, I have to say, wow, that is really impressive. So many things you take care of, and I know you even implemented PrEP in times of war. You are doing such a wonderful job. Let me just say that because the last two presentations were really touching to me.
Дуже дякую, Анет. А енергію від вас теж.
Thank you. Yes, but energy, we take energy from you too, by the way, from the support from family, from support from close ones. You are also our family. Because it seems to me that during meetings like this one, a very important thing is not just to convey knowledge and information, it's the atmosphere of support. It's important to us. Okay, Olena, now it's your turn, your impressions. Dear Annette, thank you so much for wonderful, kind words. It's really important to us as support because it's thanks to your support, and it's not only emotional and support and psychological support, but financial support. You know, so many people have been displaced, and Europe is supporting our people who were displaced. So we continue our work, including thanks to your support. So that was important to mention. And also, I would like to say again, thank you, because I've heard very important things that I didn't know before. To me, the explanation was important. What mixed feeding, for example, is. In my imagination, I could not understand why, what could be not safe about it. Now I get it, it's solid. But if we are talking about mixed like milk and formula milk, no risk. And we couldn't maybe understand that before and explain to our mothers, but now we can. And now I'm going to use that in my work. And thanks to Svetlana, actually, Svetlana was the first person in Ukraine who started to talk about that, for example, people living with HIV, both men and women, are normal people, normal. And you mentioned normality, and I agree with everyone. So we need to support and promote this normality for people, first of all, people living with HIV, to understand that we are all normal. We are different only in taking or not taking some drugs. So regardless of viral load, whatever, so we need to talk about you equal you, but the most important thing is normality. And for me, it was really something that I put it down for myself about normality. And thank you for mentioning, for saying that a woman needs to take her own decision. Yet we need to support her, like by providing the full information for her decision to be well weighted, so she would feel the right to choose and the right and responsibility as well, because she is the one to take that decision. And when I mentioned the barriers with regards to making a choice, although I think it's one of the most important reasons, but I missed it for some reason. Criminalization of HIV transmission. Still in Ukraine, we have a criminal code article to say that there is a criminal liability for HIV transmission. Still in Ukraine, we didn't have any cases that women were taken to the court for HIV transmission, but it's still there. And until we do something to stop it, like, I mean, to take this article out from the criminal code, and I'm sure that we will be able to do that. And all that work, advocacy work, is happening during war times now. But until we achieve decriminalization of HIV transmission, it's another barrier for a woman making adequate decision, because not safe for her, because potentially it's a threat of transmitting HIV to a baby and possible criminal liability and possible imprisonment. So that's the thing that I wanted to mention. So thank you. Yeah, criminal liability is a bad thing. But probably it's worse for stigma. It's worse for stigmatization. But it's not applied in practice. That's true. I agree with you. I agree with you. That's right. When everyone thinks, well, she shouldn't be breastfeeding, otherwise we are going to take the baby from her or maybe take her to the court, it's just worsens the situation. It's not getting it better. So, you know, it's too harsh. It's too punitive. So, and this approach brings no benefit. But when we try to help and to support, it's a different thing. You know, I like the fact that you liked Annette's logo or slogan about normality. Okay, Galina, maybe you wanted to say something before we give the floor to Annette, and she is the most important person today for us because we are learning. I just want to say thank you to everyone. I just need to rethink everything again. Thank you. All right, dear Annette, and the floor is final because you are the leader, the head of our today's meeting. From my side, is just to say thank you so much. It was really comfortable to be here with all of you.
Svetlana, what can I say in the end? First of all, I'd like to thank you, Sergey, Olena, Galina, the translator, the technical staff who made this possible. A huge thank you to everyone. That was so inspiring. That was so important, really, to tell you. And Svetlana, you said we are like a family, and like in every family, we can only be strong together, and that's what we're trying to be during these times. And so I'm already looking forward to the 13th Wave Ukrainian workshop, and if I can make it, I'll sure join you if I give a talk or not. It's so important. It's one of the most important projects of Wave, and we have to keep it and carry on. Well, with that, maybe I can still add or should add that next week on 4th of June, we have the breastfeeding drill fix from WAVE. And again, the German-Austrian guidelines are a topic and an extended version. So we have more time, more details. And we have a case on injectables during pregnancy, more and more cases of long-acting injectables for pregnant and also breastfeeding women. So a new option is coming up. So always moving forward. So you're invited. Of course, it's in English, but for those who have the opportunity, it's free and everyone can join. 4th of June at 7 o'clock. It's 1 hour event. And with that, I can tell you I'm going to miss you all. It feels good. It always even it's online, it's such a warm atmosphere, and that's because of you. Stay healthy, take care of yourself. Please, please, please. I'm always watching the news. Please take care of yourself. I want to see you again healthy the next meeting. And thank you once again. Goodbye to everyone. Bye.
Огромное
Дуже
спасибо,
дякую,
Анет.
Анет.
Спасибо. Вы
Thank you
прекрасно
so much,
выглядите.
dear
Мы
Annette.
обязательно
You
будем
look
хотеть, чтобы вы принимали
wonderful. Of
участие
course,
в
yes.
следующей
We'd
встрече.
like you
Мы
to participate
гордимся
in
тем, что
our
у нас
next
на встрече
webinar. We are very
звезды.
proud
Понимаете, я
that
смотрю на вас
at
и говорю,
our
цветы.
webinars we have
У
real
нас же
stars,
звезды. Это
real stars,
настоящие,
right,
ну,
Sergey?
такие
Yes,
мощные люди, мощные
real,
женщины,
powerful,
которые
strong
продвигают,
women that
You are the
свои
are
powerful one.
empowered.
Thank you.
Дійсно,
Спасибо
Анет,
огромное,
щиро
Анет.
дякую. Шановні колеги,
Yes,
дуже вам
thank
дякую.
you
Я вже
very
другий
much,
день
dear
в
colleagues.
оточенні дійсно
For
прекрасних,
the second day,
сильних,
I'm
професійних,
surrounded
дуже
by
розумних і
wonderful,
красивих
strong,
жінок.
professional,
І хочу сказати,
smart,
хочу
very
нагадати,
beautiful
що наша
women. And I would like
13-та
to remind
сімейна
you
зустріч
that our
відбудеться, власне,
13th
2 і
family
3
meeting
жовтня
is
цього
going
року.
to take part
Тому,
October
в
2nd
принципі,
and 3rd this
вже
year.
восени ми з вами зустрінемося
So
ще раз.
in the fall, we will meet
Шановні глядачі, не
again.
забувайте
And
заповнювати
dear participants,
опитувальники, щоб
don't
отримати
forget
сертифікати.
to fill out the
Пересилайте
survey to
посилання на
get
запис
the
всім своїм колегам,
certificate.
тому що воно
And
ще
please send
декілька
the
днів
link to
точно
this
буде
recording to
доступне
all of your
на
colleagues because it's
YouTube-каналі
going to be
EAX.
available
І
at our
що, побачимось.
EX YouTube
Все,
channel
всім
for a
дякую
couple
за
of
участь.
weeks. So see you next time. Thank
До
you.
зустрічі. До зустрічі.
See you next time.
До побачення.
Goodbye.
До побачення.